All right. Today's speaker is Andrew White from Scripps Clinic. Thank you for indulging me to take a couple of minutes of your presentation. So come on up and present.
Thanks. It's great to be here, be back here. I see my presentation from last year on the laptop here, so I could just pull that up if I couldn't get this one. Yeah, you guys have a really great community of allergy up here. I was talking with Glenn about that last night, that it's not every place is like this, where allergists from different institutions actually play well together and collaborate and are able to foster the kind of community that we need. So today, I'm happy I'm talking about AERD, and I'm going to sort of take this a little bit maybe different than a traditional talk where we just sort of talk about AERD and start with the pathophysiology. So I'm going to actually go through this kind of like a case from a patient that presents in your office, and how it may sort of play out in real life. Because I think that's sometimes the difficulty. They don't just walk in saying, I have AERD and this is what we should do. All right, so we'll say this is a 32-year-old female who comes to see you from ENT after being diagnosed with nasal polyps. Surgery is being recommended. And of course, her perspective is that the intention is to get allergy testing to find the cause of the polyps so they don't return, right? All heard that before, and sort of try to change the narrative at the early part of the visit. And so, patient has a dog, works as a server, is a non-smoker, has been on fluticasone, OTC spray, not working. Cetirizine does nothing. Just I always love when patients describe a medicine as doing nothing. And then takes some occasional albuterol inhaler for exercise. So you do your exam, and there's body turbinate. Patient does have a hyponasal vocal quality, but you don't see any polyps. And then nothing else on exam. Anyone know on anterior rhinoscopy what the chances of seeing polyps are if they're there? Yeah, so it's about like 80% of the time you'll miss it, roughly 70 to 80% of the time. So if you see them, obviously it's a big clue that you know what you're dealing with, but the absence of it on anterior rhinoscopy isn't really enough to say that there's no polyps. Okay. So now I've got this patient, and we're going to think through, like, what are we going to do? We're going to get to AERD, so, be patient here. But, one of the first questions is this patient atopic? That's sometimes what they're expecting. And the reason I put this up here is, what would be the value in someone that has polyps to do this atopic evaluation? Some of it is, I think, common sense. If they have a pet, you want to find out if they've got comorbid allergic rhinitis. But if you really think through it, like, why would we do the test? What are we going to get out of this that's going to be helpful? And so this is a really interesting study. Those of you that are more than 5 years into your career, this was actually an MOC article 3 or 4 years ago. So Madhavinya did this when she was in Chicago. So they looked at their big cohort of patients with CRS, and then they defined the group that had atopy and the group that didn't have atopy. And they defined atopy as actually positive skin testing, but with symptoms. Kind of allergists adjudicated whether they thought that this patient was actually atopic or not. And then what they did, which was great, they had a ton of clinical information. And so if you were atopic and you had CRS, there were some features that were, different about you. You were more likely to have polyp disease. You're more likely to have comorbid asthma. You're actually more likely to have AERD. And so these are things that, maybe having that piece of information about being atopic would actually influence you in terms of how you think the patient's disease course might go. The other thing they did that was really interesting is they had structured histopathology. And so not only were some of these clinical differences seen, but there are actually differences in the character of the inflammation. So you can see here differences with more patients having fibrosis, more patients having the Charcot-Lyting crystals, and eosinophil aggregates. So I think this is a way to think about when a patient comes to us and they're there to get allergy testing to figure out whether we can figure out the cause of their polyps. Well, that's not really the right way to think about it, but it is a way that we can say, well, you're also very atopic, and that probably is going to influence a bit of what we think in terms of your disease. Yeah, it is interesting. So here, I mean, in this group, there was less um, fungus seen on the pathology in the yeah in atopic. So I don't have a good explanation for that, other than maybe that's like a almost like a different disease. Um, yeah, I don't. They did report the allergens that were tested for, and I don't remember if there was any correlation with one single allergen. That's a good question. Yeah, because you could make a case that maybe a lot of this is driven by a smaller group of allergens. And so that I did want to bring up this concept. If you follow the sinus literature, you'll see this coming up more and more. I think this was first described, yeah, 2017. This was the first description that I have down there. So this came out of Emory. This is called central compartment. I should have put atopic disease, central compartment atopic disease. Have you heard of this before? Anyone heard of this? So um, this has been described as a medial to lateral progression of the sinus disease, and I'll show you a CT scan. The interesting thing is that it's, as the name implies, which I forgot to put off the titles, central compartment atopic disease. These patients are uniformly or universally atopic. And if you look at this CT here, you see that the disease, the polypoid disease, is really clustered centrally. And we don't see much involved in the maxillaries. So the idea here that's being proposed is that this is actually a polypoid inflammation that's actually potentially being triggered by allergen contact to the mucosal surfaces. So it starts out centrally, and then as the osteometal complexes get obstructed, it can start to spread more laterally. And the reason I think that this is important is that there's now many studies with big series that show that this description of this central disease in atopic patients tends to be milder. They tend to have less recurrence after surgery. They tend to have less asthma. So it may be a unique way to think about it. And then the big question is, would allergen immunotherapy modification actually change the course of the disease? Which I don't think we really have the answer to. I think that's true, but you don't. So I think if you see that at the very beginning, maybe you don't know, like at the very beginning of their disease course, whether that's the beginning of normal polyps or something like this. But I think the difference is here that it's sort of isolated well into the disease still centrally. But you're right, that is still the epicenter. And so this is the opposite. It's something that so it's easy here, but so this is not central compartment disease, and there's actually something on the CT. I think that's a really important teaching point. And if you were looking at this, even on my screen, it would be very difficult to see that there is actually some heterogeneity in the maxillaries. And if you change the contrast, this is what you see. So anyone know what this would make you think of? So this should make you think of fungus, allergic fungal sinusitis, okay? And so that this is a real important point. It's sort of subtle on this initial image. You can actually see it if you look at it, but if you change the contrast just on the CT, you see this. And so this is one of the findings that you would see with allergic fungal sinusitis, this heterogeneity. It's not unique to that, but it should make you think of it. And those would be the features that you would see. You'd see the classic allergic mucin, this like thick peanut butter paste. The surgeons can tell you basically when they go to the OR, like immediately what it is. And then you can see the Charcot lighting crystals here on the right, and then the pathologist can identify the fungus on the histopath. Okay, so we talked about doing that allergy evaluation. We think about this, central compartment disease. What about getting biomarkers? So we're very accustomed to doing that in our patients now. We want to know what their absolute eosinophil count is. We think about their IgE level. So, do we have evidence for that? Does it influence our decision making for polyps? Potentially. So, and we'll circle back to that. But this really brings up the question of the prevalence of a T2 high signature in polyp. And this is a study that I hope you're all very familiar with. This is the Northwestern group, their sinus center, really a couple of years ago defined these inflammatory endotypes. So they looked at all CRS, but what we're really interested in is, the differences with CRS without nasal polyps and CRS with nasal polyps. And if we focus on the polyp group there on the right, and you scroll down to right here, you can see that 87% of that group had some level of T2 high inflammation. It could be mixed. But also interestingly, I think it's intriguing that 13% didn't seem to have evidence of T2 inflammation. They were either untypable or they had something else, T1 high or T3 high. So I think the important point of this is that we do like to think about polyp disease as being just sort of like a cut and dry T2 high disease that we don't necessarily need biomarkers to predict response, because that's how the studies were all done. None of them, required biomarkers. But at the end of the day, there's still more that we don't understand about the heterogeneity of this disease. It's TH17. Yeah. Yes, they also call it T3 just to make it even more confusing. Yeah. Yeah, I don't know. I mean, of course, why couldn't they name it T17? Okay, so I don't like this idea that AERD is heterogeneous as well, but it is. So there's a lot of studies now, I shouldn't say a lot, but several studies that are, very high quality that look at the same sort of idea. You can see in the left pie chart that they go by type 2 high, blue is type 1 or 3. So either one of those subtypes, and then the gray is other. And I would have liked this to be 100%. I feel like, the AERD patients tend to have a lot of similarities, I feel like a lot of similar responses to biologics. And yet there's still a lot of heterogeneity here. And I think this just makes the question about what's going on even more interesting. What are the other layers of inflammation here? And there does seem to be in these studies, there's this very strong T2 component. The interesting part is there's something that obviously separates AERD from the rest of the pack. And so it may be the presence of some of these other dominant inflammatory mechanisms additionally, on top of a T2 component. Okay, so back to our workup. So talked about doing some allergy testing. We may get some biomarkers, even though that probably isn't necessary for the polyps. And then asthma evaluation, right? So she's using albuterol occasionally. So if you had to guess what percentage of asthmatics have CRS with nasal polyps, I'll let you pause for a second, pick a number. So somewhere in that range. And so if you this is looking at it the other way now. So if you have CRS, you're going to have a large group that has asthma, whereas if you have asthma, a smaller group will have comorbid CRS with nasal polyps. Those numbers are variable in the literature. You can, find other rates, and a lot of it is going to depend on, if it's severe asthma, then the nasal polyp burden is going to be higher in that population. And if it's CRS with nasal polyps, you're going to have a higher rate of underlying asthma. But I think the take-home point for this slide is if you've got sinus disease, you're more likely to have asthma than the other way around. And so if someone presents with sinus disease, we really should do our due diligence to understand if they have asthma and if it's poorly controlled. Okay, so I'll give you some evaluations. So there's atopic to dust mite. You find that she's got mild obstruction with reversibility. Exhaled nitric oxide is elevated at 65. So now we want to talk about AERDs. So what is the likelihood, if you had to just pick a number and not ask any more information, what's the likelihood that this patient has AERD? So we're going to say has polyp disease and comorbid asthma. So pick a number out of your head. Yeah, that's a good way to think about it. I'm going to show you the slide. I guess I put them in the wrong order to answer that question, but I'll show you the data on that in a second. So, but obviously we're going to ask this patient, hey, do you have any problems if you take NSAIDs, or are you allergic to NSAIDs? Or we look on the allergy list to see if someone ever noticed there. And so it's important, this question at the bottom, what percentage of patients with AERD will actually answer no when you ask them about NSAID reactivity? And the answer is about 15%, 1 in 8. So you ask them, sometimes it may be the way you ask the question is, do you have allergic reactions to NSAIDs? Like, no. But if you asked, if you take ibuprofen, does your nose get stuffy? The answer might be yes, right? But the other part is that when you do challenge studies of people who say, I'm totally fine if I take an NSAID, and then you give it to them and they clearly have a reaction. So that adds up to be about that 15%. So I'm always teaching my fellows, you have to ask this question maybe a couple different ways. Don't just ask, are you allergic to these medicines? I'll ask, what do you take if you have a headache or a migraine? And if they're like, well, I only take Tylenol. Why do you only take Tylenol? Because, I feel well with these other ones. Okay. So you're going to ask about NSAID reactivity. We're going to ask about alcohol reactivity. There's the answer to the question. So if you look at patients that have in the asthma population, it's around 10%. It goes up as you get to more severe asthma. And if you look at it the other way, if you just have sinus disease and you're not asking about asthma, it's also around 10%. You start to add in both of these, so patients that have more severe asthma and also comorbid nasal polyps, that actually the rates start to get up higher. And so there's a much higher chance in that population that the person might have AERD. And I think that's important. That's partly why we talk about this, is you have to think a little harder now because we've got all these tools that are disposable to treat T2 inflammation, right? And so you don't always have to ask the question. You're just like, whatever, like we'll just treat you, but I'm not going to actually think through what else might be going on underneath the surface. Okay, so what else can we do to help identify AERD? So here's some of the features that I think are evidence-based that I use in my practice. So, patients that are completely anosmic, that is definitely something that is more associated with AERD versus the person who has hyposmia, so just a deep diminished sense of smell. But if they tell you, I cannot smell anything at all, that would make me think a little more about AERD. I'm going to show you the Lund-Mackay score in a second. Polyp regrowth rate is another important feature. And so we know, in the era really before aspirin therapy and before biologics, the polyp regrowth rate for AERD patients was often measured within months. So 6 months later, they would end up starting to have recurrence. And, these are the patients that we've seen over the years that had, 10, 15 surgeries in their life. And then alcohol reactivity, which I'll talk about as well. So if you're not familiar with the Lund-Mackay score, I think this is important for two reasons. Number one is that it is something that we can use as clinicians, not necessarily doing the score, but just thinking through, as I'll show you in a second, the pan opacification and how that correlates with AERD. But it's also important just because this is something that's now reported in a lot of the sinus studies. And I think, as experts in sinus disease, we need to understand what this is talking about. So the Lund-Mackay score, you're basically taking these 6 areas, so frontal, maxillary, the anterior and posterior ethmoids, the sphenoid, and then the osteomial complex, and you're scoring it with 0, no disease, 1, partial disease, or 2 is complete opacification. So those are the outcomes. The worst score would be 24, meaning whiteout, everything is completely opacified. So that's a score. And then you can do that score at the beginning of therapy and then somewhere later date to look to see if there's improvement. Yeah.
Like, in order to have it uniform, who's reading this application based off of, like, they're not an expert, but it's not based on just like looking at it.
It is based off of looking at it. Yeah. So they'll usually, I mean, in a study, they'll have a blind radiologist usually reading it. But some, I don't know, in your radiology reports, some places will report the Lund-Mackay score as a full distinct score. Yeah. But I don't think it's, I mean, you can do it. It's not, I mean, it's either totally opacified, there's a little bit there, or there's nothing there. So it's, yeah. So this is a bit of an older study now. This came from UVA with Larry Boris. And so they looked at the Lund-Mackay score. So the score here goes across the bottom. And then they looked at the rate of AERD, or the prevalence of AERD. And so as you can see on the left, the AERD patients had a much higher Lund-Mackay score. Very few of them in the AERD group actually had a very low score. And Larry told me after the fact that one of the patients that had the high score here, that was thought to be aspirin tolerant, actually ended up having AERD later on. And so this is something that I think it's not, diagnostic, but you can also put this into your algorithm. The person's completely anosmic, even though they tell me they're not having any NSAID reactivity, they've got total whiteout on their CT, they've got asthma. So now we're thinking that prevalence of AERD is going from maybe 20 or 30%, maybe now into, 70, 80% chance. And you're going to maybe, be a little more forceful about talking about doing a diagnostic challenge in that patient group. This is talking about the recurrence rate. So this is a Japanese study and a Japanese scoring tool called JESREC. But what the whole point of this is that the patients that were the most eosinophilic clustered in over here, so aspirin intolerance, comorbid asthma, and NSAID intolerance. If you look at these different groups based on recurrence after surgery, the patients that did the worst, that had the fastest relapse, was that group, the patients that had aspirin intolerance, comorbid asthma. And so that's why we really care about thinking through this disease, because it tends to have a worse course. And if someone tells you that in the past they've had a few surgeries already, within a year or two of each other, that's another sign. Okay, so now I hopefully gave you some tools just to think through stratifying a patient that comes in, like this patient who is really walking in the door saying, I want allergy testing. And now we're saying, maybe we find some of these other features on the CT where we're saying, wow, you've got a lot going on here. I actually think there's a chance you may have aspirin reactivity. So there's some other interesting aspects in AERD, and these are sort of like people talk about them, but there's not as much literature on it. But I think this is really important. This is why we still need to care about AERD, is because it has some systemic manifestations. So we'll look here at the box. So some of the interesting features, it is adult onset in almost everybody. About 50% of people describe it starting after, they can almost tell you the day it started. I was fine until I got this cold. What they interpret as a cold, we don't know that that's what it is. But then, ever since then, they've had progressive sinus disease and asthma. But some of the other features that are interesting that I want to call out are coronary vasospasm, esophageal eosinophilia. And this all is reported out of the Brigham. They have a really great registry that was able to capture that these rates are much higher than in the general population. And then also perimenstrual asthma and sinus symptoms.
I want to go back to the first point about empathy is not. This is the traditional presentation. In the old days, we used to call these people intrinsic asthmatics, non-atopic, adult onset, and yet you showed that 4% are atopic, and if they're atopic, it has you know, it has bearing on their disease. So, I don't know if anybody remembers that old term of
Yeah.
sake of extremes.
Mhm.
If you want to comment on that.
Yeah. Yeah, this definitely, you know, I think that was still in vogue when I was in training, that concept. I do think, you know, in AERD, I think that the influence of atypy is still less clear. I mean, we definitely know that there's a very high rate of positive tests in patients that have comorbid allergic rhinitis, but whether that really totally modifies AERD, I think is less clear. Um, but you're right. I mean, for a long time, we just thought like if you had AERD, you didn't have allergy. Like those were almost like mutually exclusive.
It's a little like food allergy.
Yeah.
You can be sensitized but not allergic.
Yeah.
You have positive tests that don't bear on the disease.
Yeah. Yeah. So this is a really interesting study. It came from Japan. So they have a group of about 150 AERD patients at the center, and they reported these symptoms that we also see in our patients. And I think one of the most intriguing ones is angina. So chest pain. Many of these patients will have evidence of some cardiac involvement. They'll go in, they'll have a troponin that's elevated, and then they get a cath and it's clean. And so the presumption is that they are having coronary vasospasm. And some of these patients, it's recurrent. It continues to keep happening. And we had a case of a relatively young person who went into complete heart block during one of these episodes and had to, you know, get an emergent pacemaker. So very, very interesting. The other are episodes of abdominal pain, not just during aspirin challenge or aspirin ingestion, but also episodically. And then similar, these patients that also have a lot of spontaneous cutaneous symptoms. The authors here reported that it's not common, but it's also not rare. And they also showed, this is, I think their data goes back a long time into the really the era when omalizumab came on the market. They just reported it now, but they report on a group of patients that had these extra respiratory symptoms and showed that in the patients that were the most significantly affected, so for example, this patient here had respiratory symptoms during the challenge, also had chest pain, GI symptoms, and cutaneous symptoms. And then in the year before starting omalizumab, had 31 episodes of angina like chest pain, and that went down to 0 after starting omalizumab. So the point of this article was to share that not only are these episodes of extra respiratory symptoms occurring, they do seem to be linked to the disease and they're responsive to omalizumab in this group. And this group and others, especially in Japan, have showed that, you know, there's definitely a reduction in leukotriene levels and other, you know, mechanistic findings that support its benefit. So I think I would say from a clinical standpoint, what I have gotten questions most about in the last year or two is actually the angina in these patients, because it's very challenging. You have someone who has, you know, maybe a peripheral eosinophil count of 800, not ATS range. They don't seem to have EGPA. They've got AERD, and they're having angina-like chest episodes. You know, how do we approach that? Could it be related? And I think now there's enough evidence to say that there's definitely a subgroup of these patients where it's related to the disease.
Anybody with heart damage,
Okay.
Cooney syndrome?
So now I'll have a few slides on mechanism. There's not a right answer here. When I give the talk to the fellows, I make them pick, and everyone has to sort of justify their response. What do you think? Anyone want to put a nickel down? So I think you could look at that from a couple different ways. I think that's a very valid way to look at it. But it's really, yeah, it's interesting. I mean, we don't know. There's no right answer here. So I'll sort of make the case for why a couple of these could be true. So PGD2 actually does rise up as something that's interesting. So this is this big study that Katie Cahill did when she was at Brigham, and they looked at patients that had AERD and compared it with aspirin-tolerant asthmatics. They all got put on aspirin therapy, so we could see what aspirin does in patients who don't have AERD. It's important because very few studies have done that. And, you know, there's a paradox that happens in aspirin treatment in AERD. The patient's tryptase actually goes up. They can have a rise in their peripheral eosinophil count. Their LTE4 level doesn't really go down, although they are less responsive to that, we know in other studies. But their prostaglandin D level, the one inflammatory mediator that does seem to go down is their prostaglandin D metabolite. Sorry, I should have showed it to you here. And you can see that effect is not really seen in the patients that are aspirin tolerant. It's interesting. So this is always raised in my mind, this intriguing concept that some of the benefit of aspirin therapy may just be its effect on PGD2. And we know PGD2 is definitely important from this study that also came from Brigham. These are patients that if you desensitize them, they have these horrendous GI reactions. And in that group, there was a big surge of the prostaglandin D metabolite. And it's also simultaneously being suppressed by aspirin. So you're basically putting your foot on the gas and the brake at the exact same time. And in a lot of the patients that don't have the GI symptoms, you see a small rise in PGD2 and then it goes down quickly because the COX-1 effect is taking over. And here that takes a lot longer. And so the surge seems to go higher and it's not as well suppressed. And so they did a great job really laying the groundwork that a lot of that effect where these patients are doubled over in abdominal pain and they're flushed is a PGD2 effect. So this is, I've just got a couple slides that just say the same thing. So when we think about the mechanism or what may be the most important, I do think PGE2 also becomes like a really important player because a lot of what we know about AERD sort of hinges on PGE2 and its receptor, the EP2 receptor. So on the top left, that is holding the production of the leukotrienes in check. So you can see it's got that blocking effect through the EP2 receptor. Through the bottom, the production of the PGE2 is actually largely coming from COX-2 with some collaboration here with COX-1. And I'm going to show you all this outlined a different way in a second. But these sort of are all competing together in this, it seems like a very tenuous balance of everything being held in check. And if you lose enough of that, then you start to develop the AERD phenotype. So a couple points, data points, and then I'm going to walk it out in a different way. So we know in patients that have AERD, they have impaired upregulation of COX-1 and COX-2 in their fibroblasts and abnormalities in the PGE synthase expression, which makes the PGE2. The lack of COX-2 then depletes PGE2 and it starts to feed on itself. There's an interesting effect on mast cells that also is affected by this loss of PGE2. And then IL-4 receptor can actually further, IL-4 action through the IL-4 receptor alpha can also further suppress this. So let me show you what it is. So this would be sort of a normal, you've got a lot of COX-2 activity. That's going to end up giving you a strong signal through your PGE system. You're going to make a lot of PGE2. You're going to have a lot of PGE2 to activate on your EP2 receptor. Okay, so now the AERD fibroblasts, they don't make enough of this COX-1 and COX-2. So the arrows start to get a little smaller. You're going to start to have less output here from the bottom. It's a little smaller now because the lower the COX-2 that you now have less PGE2, less going through EP2. And then if you've got a state now where you have a lot of IL-4 activation, that's going to further impair that. And so you can see how there's like probably multiple hits to this pathway. And the end result seems to be focused on PGE2 and EP2. And then interestingly, the effect on mast cells with PGE2 is they can create more of this decoy receptor for IL-33. And so you lose that. And so now IL-33 is actually going to be much more potently acting on the mast cell.
These people already kind of feel inhibited, right?
Yes. So
That feed into this story.
I know. So it seems like if you were consistently taking a COX-2 inhibitor, then you would have even worse problems. And I don't really have a good explanation for that, although I don't know that anyone's really studied it. But you're right. If you take a COX-2 inhibitor, you don't have any reactivity. It's the reactivity is COX-1. Some of it is probably that COX-2 is so COX-1 is constitutive, and whereas COX-2 is an inducible enzyme. So some of it may be related to that as well. But I don't have. That's the one question I was hoping nobody would ask. Have a good explanation. Yeah. 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 I mean, it's still really an enigma, and there's other like that concept itself really argues that there's still something, still some things about this disease that we don't totally understand. I'm gonna skip this slide for now. Okay, let's talk a little bit about treatment in the last section. So we've got a lot of treatments now. We've got the conventional topical steroids. We've got sinus rinses or exhale delivery mechanisms. We've got the leukotriene modifier drugs. We've got aspirin therapy, and we've got a bunch of biologics. Three of them that currently I think are used the most because they have both indications, so asthma and CRS with nasal polyps. We know Tezi had positive data for their polyps, and so that's probably coming for polyps. Benra is the opposite. I think they've stopped their plan to get an approval for polyps. Depemokimab is coming, so the long-acting IL-5. There's surgery, obviously, which I think has an important role to be considered, and then diet. And there's actually the study that Tanya Laidlaw did looking at modifying the omega-3 omega-6 ratio, and it actually does have benefit on symptoms and the arachidonic acid mediators. Okay, so let's go back to our patient. So the 32-year-old female has been considering sinus surgery, but saw an advertisement for a biologic and now prefers this. She's not undergone an aspirin challenge, but we'll say she meets a lot of those criteria. She's got complete anosmia. She's got whiteout on her sinuses, maybe some alcohol reactivity. So we think there's actually a chance you've got AERD. So here's the questions. Would you do an aspirin challenge? Would you just start her on a biologic? Because that seems to be what she's interested in. Would you say, I really think you should get surgery first, and then we'll talk about the biologic? There's not a right and wrong answer here. I hear you're having a pro-con debate next week about surgery. And so, I think this is a dilemma that we face a lot. I don't know if you guys do, but we've got our ENT colleagues that we share patients with. We have our intuition and these data points to say, like, this patient may be someone who's going to relapse earlier, or they've got AERD, so we may want to approach it differently than a sort of aspirin tolerant patient. So, but at the end of the day, you've got to do something for this patient, and so it's challenging. I think of the colleagues I have, I think all of them would approach this a little bit differently. I would advocate that if we're unsure about AERD, we should really consider doing a challenge, because I'm going to show you in a second, we don't quite know what's going to happen once we start her on a biologic. And so that question still lingers. And it's important diagnostically as we think about the disease trajectory. Yeah. Correct. That's right. So the aspirin challenge, we would call that a challenge desensitization. We would just do it simultaneously. We had a high suspicion, and then as they go through the challenge, if it was positive, we'd say, okay, we've diagnosed you, and now in 3 hours, we're going to have you desensitized, versus in this situation, you might say, let's just challenge you to find out whether you react, and then we'll talk about our options. So you guys will probably talk about this next week, but there are some criteria that are being proposed for when to use a biologic. So this is from the Euphoria group, and they published this criteria for when to use a biologic. Their actually first point here, they say the presence of bilateral polyps in a patient who's had surgery. that's when you would think about using a biologic. And there's some caveats there that, patients that are not good surgical candidates, et cetera. But that is sort of the starting point from this group. And then they include, evidence of T2 inflammation. And so we talked about that. The biomarkers probably don't influence it, but they do include that here. And I think the idea is like, well, if they completely don't have a T2 disease, why would you use a T2 biologic? I think that's the rationale there. And then they want to, you want to look at things that matter from quality of life standpoint. Patients that need a lot of surgery, steroids, they have a high SNOT-22 score, which is a quality of life score, the significant anosmia, and then patients that have comorbid asthma. So those would be the, from that group, the best criteria for starting a biologic in a patient like ours. And they don't really comment on AERD, at least at euphoria. Okay, so we convince the patient to undergo aspirin challenge. So you do a graded aspirin challenge, and the patient has obvious congestion, sneezing, and some mild chest tightness, no drop in FEV1 at the 81 milligrams of aspirin. So remember, her nose is full of polyp. And so you talk about, well, one option is to do aspirin therapy, but it's really best paired with surgery, because aspirin has a great effect on preventing polyp regrowth. And we don't expect really much of a polyp regression. So if they're really full, that's probably not the time to put them on it. So you talk about that. Let's do surgery, and then, within a month or two, we'll put you on aspirin therapy. But she asks a good question. If she goes on a biologic, will this allow her to take NSAIDs? So what would we tell her? You put her, if you put her on a biologic, you would tell her she could take it. Is that what you're saying? Yeah.
Unless he has some medical need to take it, so I predict I don't know if the answer is.
Yeah.
It seems to me that I wouldn't push it.
Yeah. So I'll show you some info on that. I think your main point is correct. We have COX-2 inhibitors we know that we can use for pain safely. The imperative for aspirin has decreased a lot, where it used to be such an important part of primary prophylaxis for cardiac disease, and now that's sort of been walked back, especially in a younger person, it is less of an urgent issue. Okay, let me show you what few studies we have on aspirin sensitivity in patients on a biologic. So this is a study looking at dupilumab, and what you see on the left are the pre-challenge results, and then on the right are the post. And on the right, the high number 19, those are patients that had both nasal and lower respiratory symptoms, so they had asthma. And then directly next to that is 0, and that's the negative challenge. Nobody had a negative challenge. By definition, they all had a positive challenge. Then on dupilumab, that number went from 0 to 7. So 7 people went from having a positive challenge to a completely negative challenge. And then the group that was asthma in red decreased, and those patients moved over to the nasal reaction. So what that tells us is that there's a chance that you'll go from positive to negative, and then the patients who had asthma would tend to have less of an asthma reaction and only have a nasal reaction. This is a study with omalizumab that really shows about the same thing. This was a great study because they randomized patients and crossed them over. So they got omalizumab and placebo, they got an aspirin challenge, then they crossed them over and did the same thing. So everyone got two challenges, and they were treated with placebo during one of those challenges. And so it doesn't show up as well here in the way that they put this on their table, but 10 of the 16 patients went to have a negative challenge. So they also looked at leukotriene levels and prostaglandin D metabolite levels and showed there's also a significant reduction. So the patient stopped having symptoms, and we didn't see the surge of their inflammatory mediators. This is another study that shows pretty much the same thing, pre and post challenges with omalizumab. So 33 patients, which is a pretty good number for an AERD study. They had 24 weeks of omalizumab. And then a little over half, so 56% had complete aspirin tolerance, and then another 18% shifted their threshold. So maybe they initially reacted at 81 and now they only reacted at 325. And then this was the best study, and unfortunately couldn't be completed. So this is a group in Colombia, and they at the time they started the study, there were no biologics that were approved for polyps. They were all approved for asthma. And so they actually randomized their patients that they were treating into one of the biologics with AERD. And then they did a pre-challenge and a post-challenge. And their plan was to have, 20 patients in each group and be able to compare them. So they started the study. And then unfortunately, shortly after their study was started, dupilumab got their regulatory approval in their country for polyps, and they had to switch. So they stopped the study. So they have small numbers, and so you have to be really careful with interpretation. But I still love the idea, and this is the only study I know of that has sort of this comparative approach. And so I've just summarized it here that there was about 20% of patients that were blocked with benralizumab and mepolizumab. It was 40% here. Again, small numbers. One person either way would have affected the percentile. But 40% with dupilumab, 60% with omalizumab. Which I think sort of squares with some of what I was showing you before, that maybe around 50% of the time that reaction will be blocked on the biologic. So it's a great question. So I mean, it's probably, I'm guessing, mostly a mast cell effect. That it's, so I think dupilumab is probably having an effect higher up with blocking the IL-4 signal, and so it's maybe allowing the restoration of that EP2, the PGE2 and the EP2 axis. I think omalizumab, I don't know of any other reason other than to say it's probably just having a stabilizing mast cell effect, but that's just a guess. All right, my last slide here is talking about remission. So everyone's talking about remission now. It's like the hot new thing, right? And so like we need to talk about remission for sinus disease, and remission for AERD. So it's starting to be a concept that's out there in the literature. This was proposed just recently by the Euphoria group as well, is what remission would mean in sinus disease. So same concept as asthma, we've got the concept of control, but then remission is sort of taking it to the next level. So not only are there no symptoms, these patients shouldn't be needing systemic steroids. They shouldn't be needing recurrent surgery, and there really should be no endoscopic evidence of disease. That would be the sort of important thing, is they have to have been scoped or have imaging or something to show not only are their symptoms controlled, but it really seems like their disease is gone. And then just like in asthma, you're going to have a remission concept on treatment and then a remission off treatment potentially, which we're, not really close to thinking about at this point, I think. And this is just to remind you what the asthma remission considerations are now. So asthma remission, we think about that top column, remission on treatment predominantly. So symptoms are controlled with some sort of validated instrument like an ACT. Lung function is optimized. Patient and the healthcare provider both say that they agree we're in remission, and then no need for systemic steroids, no exacerbations, and then that has to go on for 12 months. And then theoretically, if you were able to remove all of their treatment, then it would be in remission off treatment. And then I've been really thinking about this. I've been a lot more active in challenging my patients who are on a biologic that we don't understand their NSAID sensitivity. We know they have AERD, because I feel like that's still an important concept, and I've actually been, the patients are interested in that when I bring it up. I feel like sometimes we bring it up and you're like, the patients are gonna think I'm crazy. Like, why would I ever want to try, to take aspirin to see what would happen? And I just frame it, like, we don't know this information. There's actually a chance with your biologic therapy that you won't react, or it'll be pretty minor. And so it might be a good idea for us to try to figure it out. And a lot of them have been interested in that. So I think it's something to consider. And I would sort of propose that for AERD, if we're thinking about like remission and what's the best we could get, we get their asthma in remission, we get their sinus disease in remission, and we answer the question about whether in that state they're able to take an NSAID or whether they still need to be careful and worry about it. And then I'll put, this is my plug for your pro-con next week, is that not all polyps are created equal. And so I think, you know, any discussion about where to place surgery in a biologic and how to approach the patient it's going to come down to these questions like, do you have AERD? Do you have central compartment atopic disease? You know, do you have comorbid asthma? Because those things I think really affect how we approach the treatment. They should because there's very different remission rates or relapse rates after surgery. All right. Sorry, I only left 3 minutes for questions, but I'm happy if anyone has any. Yeah, Hannah.
Even if the patient isn't symptomatic, we can still recommend that we do a thorough and no on that.
Yeah, I mean, if they have like absolutely no symptoms, 0 symptoms, no one ever prescribed them an inhaler, I might not, although I still like to see the information, but otherwise, absolutely, because I feel like there's a significant group of patients who they don't really perceive, you know, like you actually have some like reversible obstruction and your pheno is really high. And I think they're also kind of in evolution, right? Like maybe they didn't have this 2 years ago, but as their disease is progressing in front of us, it's starting to develop. So also just having it to orient them, like, yeah, you actually do have asthma, and when you have colds and it doesn't go away, like that's what it is. Yeah.
Maybe they have surgery, they are on a TB biologic, but the disease is not well controlled, so presumably they have some other disease type on pathology going on. What do you do?
Yeah. So, I mean, I think that's the challenge is the patients who are non-responders, right? Because we're not really phenotyping these patients beforehand. Like you've got the bad disease, we're just going to treat you. So, I mean, we don't have any treatments for that necessarily. You know, we can use some of the, you know, like for T1 or T3 disease, maybe the macrolide antibiotics and CRS and things like that. But the truth is we don't have a lot. So hopefully that will be coming where we can say, okay, if you're a non-responder or if we had some sort of good immunophenotyping beforehand, then we would change our treatment or do something different. Oh yeah. Yeah, so about 80 to 85% of patients with AERD will have respiratory symptoms when they drink alcohol. It's very striking. It's often within minutes. Many of them will stop drinking because it's so uncomfortable. But the other thing that never happens is they never end up in the ER. It's never bad enough. Like when they take an aspirin, you'll hear sometimes the patients had to go to the ER. They were, you know, like had a little bit more of a trouble. We know some things, so we don't understand it. But the points that we do know are that it does not matter what type of alcohol. It's more likely to be red wine. People will have it with hard alcohol, so it's not a sulfites in wine thing, even though that's a big theory for why it is. People can still have reactivity despite being on aspirin, so it's not a COX-1 phenomenon, which has also been, you know, thought. It seems to go away as the disease becomes better controlled. And so there's a group of people who get sinus surgery, and after sinus surgery, they can drink. Or they go on a biologic, and now they can drink. Or they go on aspirin therapy, and now they can drink. So it seems to more correlate with the presence and extent of the underlying inflammation. But why it happens is I've not heard a good explanation for it. And sometimes it can be within like minutes. So, you know, like the COX-1 effect is, you know, an hour, 30 minutes to an hour later. And this can be like 5 minutes later, they're stuffy. Mm-mm. No. That's a great question. So I've not been doing it nearly as much. And I think, you know, for us, there was just such a profound shift when, so COVID happened, and then dupilumab had the first FDA approval. Those both happened like really close to each other. And so we went from doing this all the time as our standard of care to basically not being able to do it for a year. And I think everyone sort of had that same experience. We're like, well, we can't do this, you know, and we're like really trying not to do surgery. So let's do a biologic and we'll figure this out later. And then that sort of just changed our workflow. Um, so I am, I think it's interesting also because we have to frame it for the patient, right? And like the patient gets a lot of a vote in this idea because we don't really know quite what's truly the best. So, you know, if they've recently had surgery, those are great patients. We could just say like, hey, these are, we could do aspirin therapy. We could, you know, sort of biologic. But if they're full of polyps and they really don't want surgery, or they've already had surgery before, go over that with them, but I'm not going to push them and be like, I'm not going to treat you, you know, like I'm going to make you get surgery first and come back to me and we do this aspirin therapy. So yeah, we do a lot less of it now.
Any outside question? You know, you're listening, we got some information for next week. Very reliable. Well, thank you.
Yes, you're welcome.
Back to me.